Welcome to Raaonline. Today's topic is cancer in pregnancy. It's a very elaborate topic. So first I will start with the pregnancy. The commonest cancer in India in pregnancy is cancer cervix. So it is a commonest cancer in India and commonest genital cancer in women in India. And most pregnant women with cervical malignancies are usually diagnosed at an early stage of disease, because in pregnancies maybe the only time they are coming to a gynecological clinic, and most of these cancers are diagnosed at early stages. So that means the early stage include the stage 1A, 1 to 1B3, and the incidence during pregnancy is 1.4 to 5 per 1 lakh pregnancies. And now what's happening these days is women are delaying pregnancies, and as a result the pregnancy happens at a later age, and this old age is also predisposed to malignancy. So the incidence of CA cervix is likely to increase because of late marriages. Now why this is a problem? So the treatment of cancer cervix include radical hysterectomy with pelvic lymphadenectomy. It is a standard treatment for early stage cervical cancer if the woman was not pregnant. But however, if we were to do the same in a pregnant woman, it will lead to termination of pregnancy and the permanent loss of patient's wish to become pregnant. And another option is in a non-pregnant individual will be to give a chemotherapy, but then it is not compatible because all the chemoradiotherapeutic drugs are teratogenic, and they will also cause decrease in the ovarian reserve, and she might not only lose this pregnancy, she may never be able to become pregnant in future if the standard cancer treatment is followed in pregnancy. So if the patient is having an advanced cervical cancer with higher stages and she is in early or mid trimester, so there are still a lot of controversies about what is the standard treatment, and the treatment will basically depend upon the gestational age of the patient and the desire of the patient, whether she is giving importance to the pregnancy or whether she is giving importance to her treatment of her malignancy. So if the patient is keen on continuing of pregnancy, there is no role of neoadjuvant chemotherapy. Now what happens is, if you give chemotherapy during the intrauterine life, so they recommend only one dose, that is paclitaxel based chemotherapy, and it can be given at 3 weekly intervals. Very rare side effects of this paclitaxel based chemotherapy, they include the myelosuppression in the fetus and fetal growth restrictions. And there are other incidents, but the nature of the disease being rare, we do not know the exact incidence of respiratory distress syndromes, anemias, intraventricular hemorrhages. So we do not know what happens if you give chemotherapy to pregnant women, although we do know that it leads to fetal growth restriction and myelosuppression in the baby. Now various combinations of these chemotherapies along with the fertility sparing surgeries have been proposed, and there is a fair evidence that the paclitaxel based regimens are safe. And radical trachelectomy, so instead of a radical hysterectomy, we have to do a surgery called as radical trachelectomy, which is removal of the cervix along with the lymphatic drainage of the cervix. So it is being looked upon as the standard care if the lesion is less than 2 centimeters. If the lesion is bigger than 2 centimeters, then radical trachelectomy is a suboptimal option. Now in the pre-operative counseling, before going for fertility sparing surgeries, before going for the radical removal of cervix in a pregnant woman, we have to explain all the complications and the impact of removing the cervix on the present and the future pregnancies. So we have to definitely counsel the patient properly before operating the patient for cancer in a pregnancy.